Hi everyone and welcome to Doctors for America Livestream. I'm Aruna Muthumanickam and I'm a National Steering Committee member for Doctors for America's Drug Affordability Action Team. I will be introducing our wonderful panelists today and moderating our session this evening. I'm an internal medicine resident physician, and so today's topic is not just pressing, but one that is very close to my heart because it affects my patients and the lives of millions of patients across the United States. Before we begin, I'd like to emphasize that the purpose of these Doctors for America webinars is to provide the 20,000 clinicians and trainees in our network with valuable learning opportunities to supplement their advocacy efforts. And so we hope that tonight will be an insightful and productive session for all of you, our listeners and participants. We are very pleased to welcome Families USA and Public Citizen as our co-hosts for this session. At DFA, we have a few ground rules for our events. Rule number one, there is no such thing as a stupid question. Rule number two, speaking of questions, please use the Q&A feature on your screen to ask your questions, and then we will address these during the second half of our session. Also, look out for comments in the chat box as our DFA staff members will be dropping useful links throughout the session. And rule number three, we ask that you be mindful in your questions and comments, since everybody's at a different stage in their education and advocacy journey. For some, this might be their first step, and for others, this might be a part of their continuing education. And so we welcome each of you as you are, and we encourage patience and good intentions from our participants. And rule number four, which isn't much of a rule, it's just about a pointer, which is that we are streaming live on Facebook Live and we'll make a recording available afterwards. Now, before we begin, I'd like to introduce our incredible panelists today. Anna Kaltenboeck is a health economist known for her role as the program director of the Center for Health Policy and Outcomes at the Memorial Sloan Kettering Cancer Center, and now serving as the senior health advisor to the U.S. Senate Committee of Finance. She has worked extensively in the areas of value-based pricing, supply chain regulations, and game theory in innovation decisions. Anna, nice to see you here. Steve Knievel is an advocate for Public Citizens Access to Medicines program, leading its work on Capitol Hill. He has helped to draft, provide technical feedback, and influence the content of dozens of federal bills relating to drug pricing and access to medicines, including legislation on Medicare drug price negotiation, drug price spike protection, curbing abuse of government-granted monopolies, and increasing global COVID-19 vaccine access, and many more. He has been leading public citizens advocacy to enact bold drug pricing reform through the Build Back Better Act. And Bailey Reavis is the Federal Relations Associate at Families USA, where she helps implement the organization's work with federal policymakers and key national partners on all of Families USA's program areas. Prior to joining Families USA, Reavis worked at Voices for Progress, an organization focused on protecting our climate, strengthening our democracy, and ensuring economic and social justice for all. There she worked with members to advocate on a diverse portfolio of issues, including protecting and expanding the Affordable Care Act. Reavis holds a BA in political science from the University of Colorado at Boulder. Now, this brings us to our topic for tonight, a checkup on federal health legislation. After months of negotiation in the House and Senate, all eyes are on the Build Back Better Reconciliation bill that is currently being discussed and debated. Key provisions have been included that will ensure that our patients are able to live healthy lives and that our healthcare system is able to build back better in a sense as we continue efforts to end this devastating pandemic. As a part of the package is a proposal to allow Medicare to negotiate lower drug prices with pharmaceutical companies, a mechanism that has been used by similar countries across the world in ensuring equitable access to affordable medication. However, with a very narrow Democratic majority in the House and in the Senate, holdouts from elected officials have threatened to derail the healthcare provisions in this legislation. And this is unfortunate because it is too often in our clinics and in the inpatient setting that our patients are not able to take the medications that we prescribe solely because they're too expensive. And the pandemic has just made this so much worse. Now, about 40% of Americans state that they're not able to take the medications that are prescribed to them because they're too expensive. Now, allowing Medicare to negotiate lower drug prices has a larger impact on the healthcare system in terms of the savings that it will earn. Within the House Budget Reconciliation Package, these savings have been used to expand Medicare and to help cover vision and dental benefits, as well as to expand Medicaid to the uninsured and some of the most vulnerable communities. And patients around the country are supportive of this. According to June polling by the Data for Progress and Social Security Works, 75% of Republicans, 86% of Democrats, and 81% of independents are very or somewhat concerned by the prices of prescription drugs. And voters want the government to take action. 77%, including 70% of Republicans, say that the government should be doing more to reduce the price of the prescription drugs. The specific provisions in the Build Back Better plan are also popular. Recent polling by the Protect Our Care and Heart Research found that the healthcare provisions in the Build Back Better package are almost universally supported by voters across party lines. Now, having said all of this, I would like to turn to Anna. I'd like to start off with you. Would you be able to share with us information on the state of play in the Senate with respect to drug pricing reform?
Thank you, Aruna. Thank you for having me. And just a quick request. Would you mind speaking up or into the microphone a little bit? I'm not sure I heard your last question very well.
I apologize. Would you like me to repeat that? I'll go ahead and repeat that. So
yeah, please.
I guess what we'd like to know is if you could share with us some information on the state of play on drug pricing policy reform in the Senate as of now.
Okay, well, thanks for asking me. And thanks for having me also. So I should preface my answer to you, which may be a bit unsatisfactory to you right now, that any views I'm expressing here today and any sort of realities that I express are really my own, and that I'm speaking on my own behalf and not of Senator Wyden's or the Senate Finance Committee. And I would also add, if media is here, that this is on background. So please no direct attribution. But in the sort of spirit of answering your question, I think the best thing to sort of refer to is the principles that Senator Wyden, as the chairman of the committee, put out earlier this year. So in June, we issued some principles that really outline the parameters that would guide any kind of drug pricing reform. And I think this is what really sort of started to create a groundswell of support for negotiation in the Senate as well as in the House. And just to sort of articulate those, one component of that is that Medicare has to have the power to negotiate. Another is that Americans have to pay less at the pharmacy counter. This goes directly to out-of-pocket costs, right? Another is that prices can't continue to rise above the rate of inflation. That needs to sort of stop being a source of revenue for companies rather than innovation. Another is that we need to ensure that we extend the benefits of drug pricing reform as far as we can, in the context of reconciliation and in the context of our system as a whole. And then lastly, there's sort of this last element, right, which we can't ignore in this whole equation, which is that we do have to reward scientific innovation. That's part of the backbone of sort of American scientific progress and medical progress in this country. We want to make sure to support that. So we're trying to also create avenues to reward scientific innovation, but not gaming of the patent system. So that's sort of, all of these things are wrapped up together. That's big policy remit. And I'm happy to talk in the course of the conversation tonight a little bit about what that means to me, at least personally, and how I view that problem.
Thank you, Anna, for sharing your thoughts on that. I understand that this is definitely difficult for you. It's a fine line to walking on, and we will definitely come back to you. I'd like to move on to Steve and then circle back. Now, Steve, what do you think about the current state of the House and Senate bills? What are your concerns? And do you have any questions for Anna with respect to this?
Yeah, thanks, Aruna, and thank you Anna, for expressing those principles and bringing those back to our attention. So before I answer that question directly, I'll just preface it with a few things. The New York Times was reporting this morning that the Democrats have been seeking Medicare drug price negotiation quite literally since I was a toddler. And, I know I look good, but I'm not as young as I used to be. Speaker Pelosi has been proposing it for at least 15 years. It was in her 6-for-06 plan. Leader Schumer has almost certainly been proposing it for as long, if not longer. Earlier this week, Public Citizen and 60 plus other groups including Doctors for America, sent a letter to Majority Leader Schumer and Speaker Pelosi, expressing that we stand with them on delivering on their longstanding priority. And I'll say too that, I'm not a prognosticator of elections by any means, but, if not now, it could quite possibly be a very long time before this opportunity comes again. Okay, so with all that said, we are a bit concerned about some of the things that we are, seeing reported on and sort of ways in which drug pricing reform might be eroded from what was marked up in the House. We understand that was, there was always like some likelihood of there being some changes to satisfy some senators as the bill makes its way through its process. But I'm just going to run through some of them and sort of talk about sorts of impacts that we think that they would have. So one thing, and Anna expressed earlier how we have to think about getting the benefits of drug pricing reform to extend as far as they can in the context of reconciliation. Hearing that fully, there have been reporting that plans outside Medicare might be excluded from benefiting from the negotiated price. There's something like 180 million people that rely on employer-sponsored insurance. So leaving out those and people on ACA plans and others, that would be, concerning. There might be issues with how how the House went about providing those prices to private plans that the Senate parliamentarian takes issue with. But, we believe beyond a shadow of a doubt that those could be designed around and that the benefits of drug price negotiations could reach the private sector. Scott Peters, you might have heard about, one of the defectors in the House. He's sort of been pressing for excluding patented medicines altogether. That would render drug price negotiations really, really weakened. Brand drugs account for something like 10% of prescription drugs dispensed, but around 80% of the US drug spend. So, excluding patented drugs would be really purposefully avoiding the drugs for which price gouging is the biggest problem. Similarly, Scott Peters, he's pressing for limiting negotiations to Medicare Part B. Medicare Part D is the largest purchaser of prescription drugs in the world. D with Delta, as in Delta, bad reference. D as in data, is the largest purchaser of prescription drugs in the world. So limiting negotiations to Medicare Part B would be leaving out the largest purchaser. The excise tax penalty has also been under attack by some more conservative members. We don't think it necessarily has to be an excise tax penalty, but without a strong enforcement mechanism, then it's hard to see how drug companies are brought to the table to negotiate. We're also hearing about and reading about potentially delaying application of negotiated prices to small biotech drugs. That would mean, some patients don't see lower prices for a longer period of time. We're seeing that the number of drugs required to be negotiated might be reduced. Again, that's fewer drugs means more patients that are left out. And finally, the bill that passed out of the House, or the HR3 bill, the bill that was advanced out of the committee in reconciliation, included an international reference price ceiling for price negotiations. And there's been pretty extensive reporting that that now is under consideration instead to use a domestic reference price standard that would be some percentage of the non-federal average manufacturer price for negotiations. That could mean much higher prices. It could mean, potentially if the private sector is excluded from negotiations, you could imagine it putting upward pressure on prices for new drugs. However, if the negotiation process is sound apart from the ceiling, and we're actually seeking fair prices in negotiations based on, rational factors like the therapeutic value of the drug and actual R&D costs and the extent to which those have been recouped in the size of the patient population, the extent by which, US government has supported R&D, et cetera, then that is less important. I'll stop there. I've laid a lot out there. But those are all. I'll say one last thing. Actually, I'm sorry. So 2 years ago, the House passed HR3 unanimously or nearly unanimously, with House Democrats voting in favor of it, including a couple of Republicans for that matter. And that in itself was a negotiated product between the centrists, moderates in the caucus and the progressives in the caucus. So now, what we're seeing is sort of a shifting where, the moderates are asking for that to be negotiated further towards less savings and not as low prices. So, it's just worth bearing that in mind as we have this conversation as well.
No, thank you, Steve. We really appreciate you bringing up those pointers. And it is almost, I would say, I can excuse my naivete, but it's almost unfortunate and upsetting to hear of these veterans coming up to the passage of the bill. And I think that before I move to Bailey, I just want to turn back to Anna and ask you, do you, I don't know how much of this you're going to be able to share with us, but do you feel like the Senate is or will be putting in measures in place to protect from these erosions of the bill? Is that something that we can expect or hope for?
So it's a great question. Here's the reality of what we're doing right now. And I say this, I will also say one thing, which is that I am learning rapidly in the course of my experience on the Hill, which is less than a year, that I am not a politician. I am policy oriented. And so I'm going to speak to this from that perspective. And I'm not going to try to handicap the politics tonight. Step back for a second. We're sort of in the weeds here. And I completely, I think that, Steve, what you're talking about reflects the frustrations of a very difficult political process that has become very entrenched. I think it speaks to something somebody asked me earlier today, which is, how do you get to a sustainable solution? How do you fix this problem? So I think there's 3 elements to that we really need to think through. The first one is, what's the symptom of the problem? The symptom of the problem to a lot of people is the affordability problem, right? They go to the pharmacy counter and they're hit with this enormously high cost, or they see their rising their rising premiums. That's a symptom. Beneath that symptom, if you start to scrape away for a second, if you were just to treat the symptom of the disease, can't call it a disease, let's leave it at symptom of the situation. If you were just to treat that, then maybe you would just cap out-of-pocket costs. And I think you see in every single proposal out there right now, yes, we would cap those, but there's more things going on underneath it. I think I've seen every single one of the proposals that are out there right now are trying in some measure to tackle what the deeper underlying issue that's here. And what is that deeper underlying issue? It's really about how companies make money and what it is that drives their success. And that success is a revenue equation, right? Every company has a revenue equation. It's price times volume. And sometimes you have to take out cost. But the reality of it is you can use one lever or the other, right? You can increase price or you can increase your volume. And we have gotten rapidly into a situation where you can trade off lower volume for higher price. Or you don't even have to trade off lower volume for higher price. And at the end of the day, what this comes down to is a situation in which if manufacturers aren't held to a standard for what they are pricing for, if they aren't held to a standard for that, if there is no market power to push back on that, than you get with monopoly pricing, which is sort of what we see in the market today. And that is a different issue. That is something that is underneath all of this that we really need to address. So then the question becomes, how do you address that bigger issue? And I think that's the layer of this problem that we've arrived at. And I think that's some of the difficulties that Steve is describing, is really that third layer, which is like, how do you do this? How do you shift these incentives? How do you redesign the system in a way that doesn't eat everybody's lunch? Because at the end of the day, there's a reality that, you know, you could pull a rug out from under everybody. You don't want to do that. You want to create a situation where you create change in the direction you want it to go, while still making sure that there's economic viability for the products that are in that you want to consume as a consumer, as a patient, as a taxpayer, that you want people to have access to. And so that's the needle that is being threaded right now. And between all of these different talking points, between all of those things, I just want to kind of make sure people realize that is where we are. We're not talking anymore about whether or not we need to cap out-of-pocket costs. We're not talking about whether or not there is a problem here. We're talking about how to get to that solution. I think that's the really, really difficult part at this point.
Yeah, thank you for your insights on this, and hopefully we can continue this discussion further as we move on to the questions. But before that, I'd like to ask Bailey to just take the floor and share her experiences through working with Families USA, why she believes this bill is important, and what we can do.
Yeah, thanks. I mean, I think this has obviously been like a very quick dive into the some of the more like wonky pieces about this bill. And I think sometimes what's important in looking at legislation is taking a step back. And as Anna said, sometimes looking at the symptom, which is affordability, and really like the person who we are trying to help, which is American families who can't afford their drugs. So I think, you know, many of us, or all of us, know that our prescription drug system is pretty broken as it sits now. And I think it's just important to remember for American families that it's honestly a painful and burdensome reality that often impacts their basic necessities of life. You know, for example, consumers facing increased drug costs report cutting back on key areas of their budget, such as buying food. And for some, the choice is even more dire. Incredibly, 3 in 10 adults, which is approximately 80 million people currently in our country, have not taken the required medicine due to the costs. So approximately 1 in 5 forego essential medications altogether because they can't afford to fill their prescriptions. So like, obviously this is a pretty widespread entrenched problem that we need to focus on. So I just think sometimes it's helpful to like take a step back and think of those numbers and make sure that we're maximizing actually solving the problem for as many people as we can, considering how widespread the problem is. And I think, you know, as Aruna mentioned some of the polling earlier, it's really no surprise that with these stark numbers and how many people are experiencing these problems or know someone who's experiencing these problems, that it's a bipartisanly supported, you know, fixing our drug pricing system is bipartisanly supported. 8 in 10 adults describe costs as being unreasonable, even across partisan lines. The Kaiser Family Foundation recently found that 92% of adults support the federal government negotiating with drug companies on providing more affordable medication. You know, we live in a pretty highly polarized world, which no one needs to hear that from me, but it's just incredible to show in that world that we live in. To think that a policy could get that widespread of support just goes to show how deep the need for reform truly is. You know, we need this bill because the problem for families is real and because voters are demanding it across the board. Like it's easy to get entrenched, I think, in some of the details and what feels, I mean, and it is important. Details do matter, and it changes the number of people are affected and how deeply, you know, or how much we actually make their medication affordable and how many people are getting affordable medication. But I think it's important to just like ground ourselves in the fact that so many people really need this reform. And, you know, I think along with everything that I just discussed on its own being really important, as Aruna also mentioned, the drug pricing is the centerpiece for a lot of the other healthcare provisions that are equally important on their own. The negotiation would be used to provide savings to the government that in turn is going to be used to fund a number of priorities. You know, I think Aruna already ran through them, but just to reiterate, you know, expanding Medicare benefits to include dental, vision, and hearing, a policy to help provide coverage to individuals who live in the 12 states that have chosen not to expand Medicaid, who would otherwise be eligible for Medicaid coverage, subsidies for the ACA marketplace coverage included in the American Rescue Plan Act that help reduce premium costs, and a bunch of other important health equity and maternal and child provisions such as Medicaid Reentry Act, funding for programs to address the Black maternal health crisis, and funding to address the social determinants of health. And similar to drug pricing reforms, these reforms in and of themselves also have extremely high popularity among voters. CBS YouGov recently this month found that there was 85% support for Medicare coverage for dental, vision, and hearing. Polling this summer found that 54% support for ACA subsidies and 68% support for the solution for the Medicaid coverage gap. So that's not even going into the tangible benefits that all of these have and the number of people that are actually being helped by the provisions, or at least ideally will be helped by these provisions, including the 37 million people who would stand to get dental coverage in Medicare who currently don't get it. And the roughly 558,000 essential and frontline workers who are currently in the coverage gap. You know, the reality is that the public is ready for and needs and is desperately asking Congress to do something on these things. And it's obviously, you know, past time for Congress to kind of take action on these things, particularly when, as Steve mentioned, you know, in many elections, let alone for decades, have been promising to make these changes to our system. So I think it's just important to remember who we are trying to make the change for and the reality of people who are experiencing that. And the politics is tricky. And, you know, no one here is going to disagree that it would be a lot easier if we didn't, you know, have to worry about that. And we could just pass the like absolute ideal thing that would help everyone. But I think like trying to find that sweet spot is important, and we can't like kind of lose the fact that we are talking about real people who are experiencing like very difficult realities, like choosing between their medication and their food. And it's really important to like actually fix that problem. And we can't just like say that we tried to fix it when in reality, leaving them in a situation that's like maybe marginally better, but like still isn't going to allow them to like be free of that choice.
Bailey, thank you for your thoughts on this. And we're going to continue this further now as we move into our Q&A section. So for this, I'm going to ask a few questions. These are questions that have been sent in from our DFA members, and then we'll move on to questions that are in the chat from the audience. So Anna, I guess our first question is for you, and this is from something that you'd mentioned, and this what really stuck with me was sustainable legislation. And I guess we'll just, you know, sort of start simple, a little easy. Our patients haven't been able to afford medications for decades now, and every time we come close, there's pharmaceutical lobbying that intervenes. And I think what I'd like to ask you is, how optimistic are you in 2021 that we can have sustainable legislative reform?
So, like I said, I cannot handicap the politics. The only thing that I can say with any degree of certainty is that I took this job for a reason, and it was to get this done. I think a lot of other people are out there who feel exactly the same way. I think the will is there. And I think part of the reason why the discussion is the tenor is so pitched right now is because we are closer, I think, now than we've ever been. And this is a political moment that's really important. I can't in good faith sit here and say I'm certain. I also can't in good faith sit here and say I didn't take this job for, you know, to sit around. I mean, everyone who is working on this bill, everyone who is working on this is there because they're absolutely dedicated to fixing this problem. So that's my starting point in everything. With that being said, I mean, this all comes back to how we overcome the reality of a very an industry that transfers a significant amount of wealth to shareholders, that creates or holds, in many instances, a lot of really old products in a stranglehold. And, you know, Steve, you said earlier, companies have this, we're talking about branded drugs. We would want to step away from branded drugs. The reality and a lot of what we see now is that companies are holding on to brands, they're holding on to patents, they're holding on to exclusivities, they're making it really hard for generics to come in, for biosimilars to come in. That's a problem we have to address. I mean, you know, a lot of the fundamental social contract that's been created over the last decades that surround the pharmaceutical industry and all of the other industries that are involved with it, right? Insurance, healthcare provision, and so forth. All of these things are shaped by that. And we really need to sort of step back and say, all right, how do we get back to those principles and make sure we're actually doing what those policies intended to do? Because we are pretty far from that right now. So I do want to sort of step back and also say that, like, there is, I think, an acknowledgement across the board that something here is very wrong and that a lot of people are really dedicated to fixing it.
Yeah, is it all right if I hop on this one too, Aruna? Yeah, so I mean, I wholeheartedly agree to that last point that Anna made. We have a severe problem where our patent system is doing, the drug companies are expert at playing games with the patent system, at prolonging their patent monopolies to extract as much revenue as they can out of those monopolies as they can for as long as they can. Yeah, and there's a number of tactics they employ that we can talk about a little bit, but but I also want to step back a little bit and respond to another piece that Anna mentioned earlier. I don't think it's correct to imply that that with sort of what passed out of the House on one end, there's somewhere in between, there's some needle that needs to be thread with, wherein we're not going to get innovation if we don't thread the needle correctly. Just a little bit of context. My colleagues, Zane Rizvi and Rick Claypool, published a report earlier last week, sort of looking at the top 20 global revenue drugs, and compared how much of those revenues came in the US and how much of those revenues came from the rest of the world combined. And for those 20 drugs combined, US revenues were more than the rest of the world combined. That held true for 17 out of 20 of those drugs individually. We're routinely paying far more than the rest of the world for prescription drugs, and it's like not even close in most cases. So there's a lot of room to lower prices without getting to a point where you're having that kind of impact. I mean, it's also worth talking about the extent by which U.S. government is already supporting early stage biomedical R&D, upon which that really forms the building blocks upon which new drug discoveries are based. $40 billion through NIH, and NIH isn't the exclusive funder. Biomedical R&D. Aaron Kesselheim, prominent, most, I think he might be part of Doctors for America. I think about it. A member. He's with Portal at Harvard. He has argued that case, so long as we continue to fund NIH, then innovation in drug development is going to be all well and good. So I just wanted to make those points quickly as well. Oh, one final, actually, I'm sorry, I keep doing this, but it's worth stepping back and thinking about like how we got to this point in the first place too. In 2003, I believe, when Medicare Part D was created, that the pharmaceutical industry was against it until they were for it, because they got the rules structured in such a way that they could profiteer off of it. And what they got explicitly was strong requirements for the US government to be required to pay for a number of their medicines, protected classes, and so on. They got an explicit prohibition on the US government stepping in to negotiate prices or do anything related to a formulary. Billy Towson was the chair of the Energy and Commerce Committee at the time. It's kind of fairly well known story in the field that, after getting Part D through Congress in the Medicare Modernization Act, he went to become the head lobbyist for pharma, the pharmaceutical industry's lobbying group, got paid millions of dollars there. So, it is, one of the most sort of explicitly corrupt stories in Washington, not the cleanliest place in the world. So what we're asking for is fairly simple. Getting rid, we want to not just get rid of that, but get rid of that prohibition and put in place a sensible structure to negotiate prices. And I don't think anyone's arguing for negotiated prices not to take account for how much companies spend on R&D, but they're like, drug companies are amongst the most profitable companies in the world. Like the big pharma companies, profit margins are upwards of 20%, which is quite extreme. They spend more on buybacks and dividends than they do on R&D. So there's a lot of room to reduce pharmaceutical companies' revenues and still get plenty of innovation.
Yeah, I mean, actually, want to respond to that. I don't want to come across here as saying that is not true. I think that I can wholeheartedly endorse the idea that there is a lot of room to cut prices without harming innovation. They are not mutually exclusive. And I think the CBO report recently that came out really speaks to that, the number of fewer drugs is really quite small in their estimate. And in their estimate, also not likely to be breakthrough therapies. I do think the issue, so it's a nuanced animal. The interesting thing about the innovation debate, and I don't think anyone has really picked this apart, but there's sort of two threads that go through it. One is, are you promising future revenue? And the other one is, are you using revenue right now to foster innovation? And I think what you're getting to is the latter part, which is that revenue doesn't seem to be going into innovation, right? So where is it going? Then there's the signal part. Are we making sure that people who are investing in new therapies are also, will continue to feel that this is a market worth investing in? And that is the needle, I think. There's another needle, which is, sustainability in terms of employment, sustain all of these things. But that to me is the core of what is going on in this industry. That has kind of gotten disconnected is this notion of somehow conflating current revenue, with future innovation.
Bailey, any thoughts on this that you'd like to add on to this?
I don't think I have anything major to add. I guess like one statistic as Steve was talking that I just wanted to flag, and I think it goes along to what both Anna and Steve are saying, is that even if sales in brand name drug manufacturing, it's a Westall study statistic that says if brand name drug manufacturing sales were cut by $1 trillion, they would still be the most profitable sector or industry in the sector. So I think, yes, obviously revenue and innovation aren't similar. I think obviously what's important here is showing how much money that the government is spending to innovate, and the idea that any kind of correlation there would have an impact when the government spends a lot of money to innovate. I mean, and I know that it was cut out of either the reconciliation or the appropriations package. I can't remember where it was slated, but the ARPA-H, department that the White House was pushing for, I think there will still have plenty of innovation, even if we significantly reduce the revenue. Those, as they both said, they're not correlatory.
Yeah, no, thank you, Anna, Steve, and Bailey on your thoughts. And I feel like we can definitely have another webinar on pharma foul play and all of the loopholes that allow them to do what they do. But I'd like to move on to our next question now. And this one is for Anna. In the last few years, we've been seeing, differing plans with respect to Medicare drug negotiation. So HR3 is very different from the Grassley-Wyden bipartisan bill. And I guess what we'd like to ask you is, what are your thoughts on the differences between bills from the House and Senate with respect to Medicare drug negotiations? Just a technical question there. And then also, what are your thoughts on overcoming bipartisan divide?
Great questions. So sort of to back up here for a second, HR3 has negotiation in its core, right? The bipartisan bill, the Grassley-Wyden bill of 2019, and its subsequent sort of children, don't include negotiation as a core component. So we're building that now in the Senate and building a consensus around that. I will say, and I think it comes back to my earlier point, companies can make money by price times quantity, right? That's the fundamental reality. On price, we should be looking to make it so that the treatments that make the biggest differences in patients' lives are the things that get the best prices, right? I think that is something that sort of is at the heart of what negotiation also means to aim at, right? And then there's another component to negotiation and to sort of any of these redesigns, which gets at the quantity component of it, which is volume. which is access, which is patients getting access to a product that they maybe wouldn't have gotten otherwise. So that's the corollary of this. I mean, if you're going to price something according to its value, then also you should be giving access to it. So that's the hope, is that whatever we land on, we need to be getting to a situation where the price and the quantity works out in such a way that people can use these products, that not only is it affordable in the sense of like an out-of-pocket cap, but that the system can afford them, and that the system can also afford to pay the best drugs, the best prices, right? So this is the trade-off in all of this. There's another component to that, and I think it gets to my earlier, and I think also Steve's earlier question of like, when do you stop paying premiums on a product? Like, when does it stop being a brand? And I think that's the other element of this, is that just because something works well doesn't mean it gets to get a premium forever. And companies have gotten really good at extending that out, right? They've gotten really good at sort of saying, okay, I'm going to keep my brand for this many more years. The idea here is like, you shouldn't be getting those revenues forever, because that's not what keeps companies hungry. They need to be looking for ways to replace those revenues, because they know they're going to go away, right? So they've made their money and they know they can make more in the future, but not by sitting on the same thing. So that's really where we're trying to go with it. And I think HR3 is going in that direction. I think wherever we're going with the Senate is also going to go in that direction. We're trying to both get there. I think the way to do it is a couple of basic principles. And it gets back to what we were saying before. Secretary needs to be able to negotiate. Payers need to be able to negotiate. We see that in the private market right now, to your point, Steve. The non-interference clause blocks that currently in Medicare for Part D. Doesn't actually in B, but that's a different question. And then the people who are negotiating need to do it in such a way that it aligns with the interests of patients, right? And, you know, regardless of which drugs Medicare ends up negotiating, the reality of it is that we still have a very large private sector that negotiates prices, and we need to be addressing those, you know, that system as well. All of this needs to start to be realigned in order for this to become a more sustainable solution. So I think once we get that right, once we get those components underneath it right, we'll have a good sort of two-step thing where we can both deal with the affordability issue, but also with the sustainability issue, right?
Aruna, do you mind if I jump in? I'll be briefer this time, I promise. You know, I can't agree more with, you know, what the sort of sentiment Anna was just expressing about sort of needing to get to a place where, you know, we don't have this rent-seeking behavior that we have right now off of drug companies just juicing every drop they can out of their monopolies, rather than thinking about innovating, you know, developing a new drug that's going to get them more revenues in the future, instead of just trying to play lawyer tricks. You know, there are, but that doesn't start and end with Medicare negotiation, to be clear. You know, that the Medicare negotiation can play a role in that, in helping to sort of, you know, make sure that that prices are, as I said earlier, and that Anna's been kind of alluding to too, that they're rational and based on the value of the drug, how much benefit they're construing. You know, but, you know, I just wanted to throw out a couple ideas. Jamie Love from Knowledge Ecology International is really one of the thought leaders in this space. You know, one of his proposals that he's put out there for a long time that really gets at the heart of what Anna was just talking about is, you know, after drug companies accrue a certain level of revenue that is, you know, some multiple of how much it costs for them to conduct their R&D costs, you know, then you could think about ending that monopoly sooner. Like right now we have a system where companies, you know, at least get their 20-year patent monopoly and, you know, oftentimes extend that further with incremental changes to the drug evergreening, you know, all the tactics that they play. But you could look at it the other way too. And, you know, sometimes 20 years is more than sufficient. You have a drug like Humira, which has generated God knows how much revenues now. I think it's north of $100 billion. It's, you know, and that benefited, I believe, from UK government funding and its development too. So, you know, right now, there's no reason for AbbVie to have a monopoly on Humira anymore. It just makes zero sense whatsoever. So, you know, beyond sort of like looking at how you do this with pricing rules on Medicare and so on, like it's really worth stepping back and reevaluating how our patent rules work altogether. Way back, long before I was born. So as long as Congress has been working on this for a long time. Senator Kefauver, to which we owe much of our regulatory structure for prescription drugs, he proposed having de facto, like after 3 years, you just license competition on patented drugs, just as a matter of course. Like that was, and nobody's proposing anything like that now, I don't think, but like it's just worth having sort of that, broader context and thinking beyond the bounds of Medicare negotiation on this stuff too.
All right, Steve. Well, thank you for your interesting insights on that. And at this point, I feel like all of my information and new data is centered around Steve's age as a timeline in my brain. Now, I think I just want to speak to Anna and Steve as well. Just want to circle back to our question on bipartisan divide. I know that you guys do have some thoughts on that, and maybe Bailey, if you could start off.
About Medicare negotiation or about the package in general? Yeah, no, good question. I mean, I think it's an issue both within this one, but also just one that's kind of happening writ large across our political system. I mean, there's clearly bipartisan consensus, as the statistics that you said, the statistics that I said, among voters on this issue. There's handedly popular support for this issue, and how we translate that to Congress, I think, is just an ongoing challenge. Like I said, like on any number of healthcare and other priorities. I mean, you look at it with gun reform, you look at it with climate change reform, like these things are popular among all voters, and yet there's some kind of disconnect into trying to get members of the other party, or as we're seeing, even sometimes members within the Democratic Party, to care about these priorities. I mean, I think I don't see any dynamics changing in this Congress that would lead to bipartisan support existing on something like Medicare negotiation. I don't think that means that things are off the table for other aspects of drug reform. I mean, I think, obviously last Congress, there was Grassley-Wyden, which granted was, in Part B, but there was support there. We've seen, Republicans talk about reforming aspects like PBMs, pharmaceutical benefit managers, which, I think at times that's kind of used as a way to distract from talking about Medicare negotiation. But we know that Leahy, Senator Leahy, Chairman Leahy, is spending a lot of time in judiciary working on things like patents and turning his attention. And we know Ranking Member Grassley has shown interest in areas like that. So do I think we can get any bipartisan consensus, or not even consensus, but interest in a time that would change the dynamics of this current debate that we're having? I do not. Do I think that there are opportunities to work in other spaces potentially to continue to move move the needle and kind of change how we discuss these issues? Possibly. But I think no dynamics are changing in the immediate term that would, I think, change for this package or this immediate discussion, in my opinion.
Great. Steve, real quick, any thoughts before we move on to the audience Q&A? We are running out of time.
Yeah, I'll be really fast. Like, this is a totally bipartisan issue. It's one of the most bipartisan issues there are. It's just not inside the Beltway, not on Capitol Hill, or not so much. Like, Bailey rattled off some of the polling stats earlier, but it's literally across the political spectrum, even after being exposed to the pharmaceutical industry's talking points about how drug price negotiation is gonna kill innovation and there's no more rainbows or lollipops either. Like that, even after hearing those arguments, 8 out of 10 Americans across the political spectrum support Medicare drug price negotiation. There was this Navigator, another polling firm, Navigator Research. They had another good one earlier today, showing the top 3 most popular things in the entire Biden Build Back Better agenda are giving Medicare the power to negotiate drug prices, expanding Medicare to cover dental, vision, and hearing, and raising taxes on the rich and corporations. That is true for independents, and importantly for economic persuadables, defined as Americans who disapprove of how Biden is handling the economy, but support the Build Back Better economic plan. So, it's really, it is bipartisan. It's just some of the politicians, and probably more, I mean, we're a nonpartisan, public citizens is nonpartisan, but there's one party that is pretty bought and sold at this point. And there's another party which is not, but has some members who are, also getting a lot of money from pharma too. So, yeah, that's all I'll say about it.
All right. Well, we're going to move on to the questions in the Q&A real quick. So Anna, it looks like we have a question for you. It says, it's from an anonymous individual who asks, I'm curious what mechanisms would be most effective in negotiating lower drug prices for my patients sustainably. I am assuming that they're asking from a individual physician standpoint or like a health advocate standpoint. Maybe you can shed some light on that.
I really appreciate that. And honestly, this is the kind of question, and even in my job before this, where I was working on policy as opposed to on the Hill, I don't have a good answer. I think, for your individual patients, the best that you can do is to direct them to the programs that on a policy basis, we know to be erosive of and inflationary in terms of drug prices. So, patient assistance programs, discount cards, whatever you can do to help them in that moment. I think you, as a healthcare provider, as a concerned citizen, and I will say this generally to anyone who's listening, I think the voice that you represent needs to be heard. I think not enough healthcare providers get on the Hill and speak to this. And I think that's an important element. Politicians are sensitive to that. It does matter. And hearing it from you, hearing it from the folks who are in this audience and the person who asked this, I think is a really important thing. I understand this sounds trite, but it is genuinely important, because when we get calls from personal offices about constituent issues, these are the kinds of things that end up triggering them. It's concerned physicians, it's concerned folks in situations of providing healthcare that actually get the ball rolling, that get people moving, that get action taken. And this is not a short process. And by the way, whatever we do to fix drug pricing today, human creativity is pretty incredible. And so the ways in which companies can game things, the ways in which people can game things, it's always, policy has to be a living thing, I think, in large part, because once you set the rules of the game, people figure out very quickly where the loopholes are and how to do all of the things that you hope they wouldn't do. And so I think it's incumbent upon the physician community and the nursing community and the care, all of the communities that are involved in delivering medical care, to have a voice in this and to sort of be the sentinels and to have that communication. And it doesn't necessarily take a big organization. It takes somebody just picking up the phone and finding the right person and saying, I have this problem.
Absolutely. And we're really thankful that you mentioned that. In the chat right now, one of our DFA members dropped in a link that our listeners can use to reach out to senators as well. I'd like to really quickly move on to the next and last question from our audience, which is, aside from patent gaming, out-of-spirit extensions, non-competitive practices, etc., what are policy solutions in your eyes to get to the problem of what our patent system incentivizes? And I guess just about anyone who wishes to chime in on this from among the three of you.
I'll jump in first. I feel like we kind of talked about this a little bit, maybe indirectly sort of answer this question somewhat. But, look, a hugely important thing is actually, as Anna has said, ensuring that we're actually, the drugs that are the most impactful, they're the most valuable to us, those are the ones that we should be paying the most for, like ones that are just replicating an already well-known mechanism of action that's like not any more therapeutically beneficial than what we already have. We should not be paying so much for those drugs. But right now we have a system where there isn't like a lot of distinguishing between those sorts of products. So, having pricing that's actually tethered to therapeutic value, having sort of rules in place that, respond, that prevent drug companies from prolonging monopolies just because they can without providing any therapeutic benefit. Like those are all things that help go in this direction.
Can I add to that for a second? I think it's an interesting thing how we capsule off patent rights from everything else. I've said stepping back so many times today, I'm sorry. Let's say this. What does a patent give you? It gives you the right to sue somebody else for making the same thing you made. That's what a patent does. It doesn't protect you from having to bring the thing to market. It protect you from having to make buyers want to buy it. It doesn't protect you from somebody else making a better version. It doesn't protect you from the supply chain saying, hey, you have to pay us more, or buyers saying, hey, we're not going to pay this much. It doesn't do that. All it does is it says nobody else can make the same thing that you are making for a certain period of time. That is all. It's something that I think gets conflated a lot in the public debate, and I think it is worth reiterating that we shouldn't elevate it to the level of protection from market forces themselves.
And I'll just quickly say, rather than going through a litany, Families had actually put out a report over the summer about how our current patent rules actually infringe on innovation and essentially keep innovation from happening. So I'll just drop that into the chat for people to read through. And one last thing I would just like to say, I guess, like throughout all this discussion, I think one of the ways to like actually address this problem at the end of the day is figuring out like, who are we centering the rules for? Are we centering the rules to like protect profits or to protect business, or are we centering the rules for the people who are actually like taking the medication and the patients who are the ones like at the end of the day who can't afford to pay their bills because they can't, or like who can't afford other things because they can't afford their bills. Like, I think it's just about reframing like who our policy is for. And I get it, like government has a lot of stakeholders that they have to worry about, and it's not like they can just like blow off major businesses and things like that. But I also think like sometimes these conversations get trapped in the idea of like, oh, we need to like make sure that we're not trimming profit margins like too much, or what about these things? And like no one's centering it on the people who are actually have the disease that requires the medication that they now can't afford because it's too expensive, or they're not eating on top of like whatever reason they already needed their medication. So I think it's just reframing about who we're working on behalf of. Which I know, like, everyone in Build Back Better, I think is working on, obviously, Chairman Wyden said today that they're like going to the mat on drug pricing. So, we know we have allies in that way too, but I think sometimes it's part of the discussion that gets lost.
Great. Well, thank you so much, Anna, Steve, and Bailey. It looks like we have reached the end of our questions in the Q&A and of our session. On behalf of Doctors for America, I wanted to thank all three of you for joining us tonight. Public service and public health advocacy are challenging fields, and we appreciate the work that you're doing for our patients. And then to all of our DFA physicians and non-DFA physicians who are listening in, I just wanted to echo what Anna mentioned, which is that it is imperative now more than ever that you stand up for what your physician or your patients believe in and deserve, which is equitable access to affordable medications, and that we encourage you to reach out to legislators to encourage them to support and pass the Build Back Better Act. We do have resources on the DFA website, and there are links to that in the chat that you can use to do this. So yes, that is all. Once again, thank you everyone for joining us tonight, and hope you have a great evening.
Thanks, everyone.
Thank you.